Welcome to the latest Hear from the Experts webinar. This series is helping people better understand multiple sclerosis and provide tools to navigate their MS journey with more knowledge and confidence. Our intention is to help you learn more about the disease, treatments, research, wellness strategies, and much more. My name is Shauna McKinnon, and for over 35 years, I was a radio announcer, capping off as an afternoon announcer and music director at Cruise FM in Fort McMurray, Alberta. I retired just a few months ago and moved back to Nova Scotia. I was diagnosed with MS almost 25 years ago, and since my diagnosis, I have volunteered for the MS Society as a speaker, moderator, and MC at many walks and bike events, and also as a participant. This year marked my 14th MS bike ride. I think it's 14. I seem to have lost track. I'm also an MS ambassador and previous council member in Fort McMurray. I love nature, especially bugs, and can most often be found playing outside. And I'm your moderator for today's broadcast. Now, before we get started with our presentation, we're going to go over a couple of housekeeping items. Your microphones have been muted and will remain muted for the entirety of the presentation. The webinar is being recorded and will be available soon on our website in English. We are also adding French subtitles to the recording, but that version won't be available for a couple of weeks. The recordings will be available on our website under Nationwide Webinars from the archive page and on our YouTube channel. Now, if you have a question for today's presenter, please type it into the chat box on the right of your screen, and we will try to get to as many questions as possible following the formal presentation, although we have received some pre-submitted questions to help us get started. The session is also being broadcast on Facebook Live, and we welcome that audience to also type any questions into their chat box. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. Speaking of the MS Knowledge Network, we do have staff, including an MS Navigator, monitoring the chats, and they will share additional information when able. Also, please note that the MS Society of Canada does not approve, endorse, or recommend any specific product, therapy, or service, but provides information to assist individuals in making their own health and wellness decisions. Also, this webinar is made possible through support from MS Can Be, plus funding support from Night to Fight MS and FUMS events. Today's presenter is Dr. Anthony Feinstein. Dr. Feinstein's expertise is in the neuropsychiatry of multiple sclerosis, and his research includes neuropsychological testing that includes brain imaging, both structural and functional, and quantification of mood symptoms. He is a professor of psychiatry at the University of Toronto and runs an MS neuropsychiatry service at Sunnybrook Health Services Centre. His research has been supported by the MS Society of Canada, the Canadian Institute of Health Research, and the Progressive MS Alliance. The MS Society-funded studies have looked at brain MRI correlation with depression, the development of computerized tests of cognition, imaging changes linked to cannabis use in people with MS, pseudobulbar effect, and more recently looking at cognitive rehabilitation and exercise in people with progressive MS. Findings from his research are considered translational in that the findings from the lab are generally applicable to patient care. Dr. Feinstein was formerly chair of the medical committee of the MS Society of Canada. Welcome, Dr. Feinstein.
Good. Thank you, Shauna. Very happy to be here. Okay, so thanks again for this opportunity to speak to you about unpredictability and uncertainty when you are diagnosed with multiple sclerosis and mental health challenges that you might face. Next slide, please. So I'm going to read a little bit from a book that I've recently published called Mind, Mood, and Memory, because I think this will set the tone for the talk that I'm going to give you. So this is a case history. Lisa recalls the moment she was given the diagnosis. She knew it was coming. Time on the internet had spelled out the diagnostic criteria days before she saw her neurologist. Being armed with this certainty does not, however, soften the blow of confirmation. To her surprise, when she gets the news, she bursts into tears. Much of the visit is spent sobbing, she recalls, so that by the time she leaves the office, she's been given not only a prescription for a disease-modifying drug, but an appointment to see me too. She enters my office with a bright, tense smile. It is a mask. I have seen countless times before in people coming to their first psychiatric consultation just such a presentation. Beneath that bright, well-groomed exterior are seas of emotions held in check by many factors: willpower, pride, fear of appearing weak, perhaps distrust. Whatever the reasons, time will reveal them, as it will the emotions that come with multiple sclerosis. Over the course of the next hour with Lisa, a familiar pattern with variations unfolds. A young life has been upended by disease. And because multiple sclerosis is so common in Canada, almost everyone knows a person with it, be it a relative, a friend, or the mother of a friend. If that person is disabled, which might be the case, then it is the image of a walker or a wheelchair that looms large over this first consultation. There is often, however, some good news to be imparted at this point. The symptoms of depression may be transient, wedded to the sudden uncertainty over what the future now holds. Lisa's low mood is distractible. Friends come around to visit and spirits pick up. The family goes on an outing and her mood brightens. Sleep may be fragmented, but appetite is unchanged, and the beliefs that are typically linked to a major depression, such as guilt and poor self-esteem, are absent. Lisa, like so many people newly diagnosed with an incurable, potentially disabling condition, is understandably frightened by the unexpected turn her life has taken. There is one more variation to the theme that needs highlighting. 6 months back, Lisa had not a care in the world. Overnight, optic neuritis rendered her blind in one eye. She bounced back from this, albeit incompletely, but just as she's finding her footing and righting her life, a leg goes numb, and she's diagnosed with MS. 2 big stressors back to back, and a new concern has now been added. She's been referred to a psychiatrist. Does this mean I've become mentally unwell too, she wonders. I often come across this worry at a first consultation, the fear of mental instability compounding the fear of multiple sclerosis. There it lies, the composite worry just beneath the bright smile that soon cracks, smudging her cheeks with mascara-tinged rivulets. There is much to be accomplished at this first appointment. Obtain a detailed history, complete the mental state examination, arrive at a diagnosis if possible, and then, in the time remaining, reassure Lisa that what she's experiencing emotionally is common to people with newly diagnosed MS. Feeling upset and worried, and yes, depressed for short periods, is a natural reaction to adverse news of this consequence. In the absence of a formal psychiatric illness, it is important not to pathologize what she is feeling. At the same time, it is incumbent to offer support and guidance, and, if needed, develop coping strategies that she will require for a lifetime. So this kind of clinical history that I've read to you is very common. I see this week after week. It's probably the most frequent reason why someone is referred to my MS clinic. So what I would like to do with you in the remaining time is walk you through an approach to mood disorders, to explain what works in terms of therapy, and to give you an understanding of how depression might come about. The next slide, please. So I think this is appropriate. When someone gets bad news, it's akin to maybe going through a grief reaction. And these are the well-described stages that people go through. Denial to begin with. Can it be that I've got multiple sclerosis? Yesterday I was well. Suddenly I'm given this diagnosis. Is it real? People can go into denial. That may be followed by anger. Why me? A sense somehow that life is unfair, that you've been singled out for a particular misfortune. The third stage is bargaining, when you try and bargain with reality. If I do this or I do that, perhaps maybe I'm not going to have this diagnosis, perhaps I'm not going to have any symptoms. But that soon gives way to the fourth stage, which is something that I'm going to speak about in greater detail, which is depression. And ultimately, and this is the challenge, the person arrives at a sense of acceptance. So let's speak more about depression. Next slide, please. So there are 2 basically big kinds of depression that you come across. One is reactive, and the other one is endogenous. So what's reactive? This is typically part of what is called an adjustment disorder. So the individual, the person with the new diagnosis has been told you've got MS, and it can be a challenge or difficult. It can be difficult to adjust to this new reality. And that can come with feelings of sadness, etc. But this is usually time limited. It may be associated with anxiety, And the treatment of choice here is psychotherapy. Next slide, please. We now know that depression can come about through maladaptive coping strategies. And we know what are good strategies and what are bad coping strategies. Problem-focused coping is good. You identify what the problem is, you try and come up with a solution for it, working with your therapist. So it's focused, it's directed towards an end, which is overcoming or working around a particular problem or emotion. Avoidance is a bad coping strategy. Avoidance solves nothing. You're just kind of kicking the can down the road where you're going to have to address it at a later stage. So you'd want to avoid avoidance. And then you have emotion-based coping, which is also not that particularly helpful. That when people are in a state of high emotion, your judgment might become impaired because of your emotion, and that can lead you to make decisions that are ultimately not helpful. And so from a therapeutic perspective, what you try and focus on is problem-focused coping. Next slide, please. However, there are times when the depression can be more severe than an adjustment reaction. And this can be the endogenous depression that I spoke about, a condition called major depression, which is defined as the following. 5 or more of these symptoms that need to be present over a 2-week period. The mood is depressed for most of the day. There's a diminished interest or pleasure in activities. Appetite changes with significant weight loss or a weight gain. You may eat too much or you lose your appetite. There may be insomnia or excessive sleeping nearly every day. There may be a degree of agitation, or the person becomes slowed down or retarded in their movements. Fatigue or loss of energy is present nearly every day. There may be feelings of worthlessness or excessive inappropriate guilt. There's a diminished ability to think or concentrate, and there may be recurrent thoughts of death and dying. And so to have the diagnosis of major depression, you need to have at least five of these difficulties over a 2-week period. And this is, more serious, more substantial than the adjustment reaction that I described earlier to you. Next slide, please. How common is this depression in people with multiple sclerosis? Now, there's good Canadian data to show that this is in fact very common. So this is a study of over 44,000 people with multiple sclerosis. There were over 220,000 healthy control individuals. The data come from 4 Canadian provinces. Next slide, please. Next. And what it showed is that the annual incidence per 100,000 people with MS of depression is high, 979 people. Anxiety is almost as frequent. Bipolar disorder is less frequent. The important point about this is that all these disorders, depression, anxiety, bipolar disorder, are increased in people with multiple sclerosis relative to the general population. What's of interest, and this is important, is that symptoms of anxiety and depression may increase neurological disability, particularly in women. And what we now know is that over the course of a person's lifetime with multiple sclerosis, between 1/4 and 1/2 of people will develop a clinically significant depression. So what I'm speaking about is very common. Next slide, please. I want to share a little bit of research data with you because I think this is clinically relevant. Someone comes to see me and they're depressed, they've got multiple sclerosis, but I take a history and they're not that disabled physically, they're still working, they've got good relationships, there are no financial pressures, and they say to me, hey doc, why am I depressed? I know I've got MS, but all these other aspects of my life are good. Well, there's some data now to show that the brain changes linked to MS may directly cause depression. Now, this is data from my research team. We showed that lesions and shrinkage in parts of the brain, frontal parts of the brain, parts of the frontal lobe, may indeed be implicated in causing depression. In other words, depression may be a direct symptom of the brain changes linked to multiple sclerosis. Next slide, please. There's also data from a German research group that shows exactly the same thing. What you're looking at over there are various MRI images. When you see those very thin orange lines right in figure A over there, this refers to brain scans in which you look at brain in very fine detail, very thin brain slices. And if you look at picture D, in the red area over there, that's part of the hippocampus, which shrinks in people with multiple sclerosis. So a particular shrinkage of part of the brain in some people may be directly linked to depression as well. The next slide, please. And the final bit of brain imaging evidence is very compelling. This is data that comes from my research team in which we looked at normal appearing brain tissue. So next slide, please. When you see those colored images of the brain on the right, we kind of divide the brain up into different anatomical areas. We remove the lesions, and we look at what's called normal appearing brain tissue. And we can extract data from that. And we have been able to show that even in this normal appearing brain tissue, there can be subtle brain abnormalities, once again in frontal areas and temporal parts of the brain that are implicated in causing depression. So I spend a bit of time going over the brain imaging because I find that my patients find this very interesting. It becomes helpful to an individual to know, well, where's my depression coming from? If it's not because I'm worried about MS, if it's not because of financial difficulties, I'm not working, etc., well, your depression may be linked directly to what's going on in your brain. And that's the data that I presented to you over here. Next slide, please. So how might you treat depression in people with MS? So let me start off with non-pharmacologic treatments. Next slide, please. The American Neurological Association, American Academy of Neurology, recognizes cognitive behavior therapy as the treatment of choice for people who become depressed. And this is a short-term, goal-orientated psychotherapy that takes a hands-on, practical approach to problem solving. Now, if you remember my first slide that I showed you about what's good coping strategies, problem solving is a good coping strategy. And CBT, or cognitive behavior therapy, can help you with this. And the goal behind it is to change patterns of thinking or behavior that are behind people's difficulties. And in doing so, this changes how you feel. So depressed people can think, no, go back, please. Depressed people can think in a negative way. Thoughts become negative. If you change those thoughts, if you identify what those negative thoughts are, then a secondary benefit is that mood starts improving and depression lifts. The next slide, please. We now know that CBT, or cognitive behavior therapy, can be given very effectively by telephone. And the pandemic has transformed healthcare. Because we've not been able to see our patients in our consulting rooms, we've resorted to using virtual care, whether it's Zoom, Ontario Telemedicine Network, whatever your platform is, even telephone therapy. And we now know that cognitive behavior therapy can be given very effectively over the telephone. Next slide, please. And this is really interesting. Don't worry about all these numbers, but just focus on those little red stars that you see. When you help someone with depression, when you give cognitive behavior therapy, you don't just improve their mood, you can change negative thoughts that they have about themselves. You can reduce somatic symptoms. In other words, physically, the individual starts feeling better. They have less physical complaints. There's an improved sense of psychological well-being. And indeed, fatigue can improve as well. So there are many benefits that come from helping a person with depression. And I see this all the time. One of the biggest is that fatigue may lessen as well. The next slide, please. This is just an overview showing you how effective cognitive behavior therapy may be. The next slide, please. You will see three different color stars over there. The green star refers to all the individual one-on-one studies that have been published showing that CBT is effective. The orange star refers to group therapy. In other words, you can give cognitive behavior therapy in a group setting. You bring together 8 or 10 people with depression. You put them through a course of cognitive behavior therapy that typically lasts 12 to 16 weeks. And even within a group setting, you can get benefits. And the yellow star there at the bottom of that slide reveals that cognitive behavior therapy can now be given via computer. There are at least 4 computerized CBT programs that are known to be effective in helping the individual with MS who has depression. And so you log onto one of these programs and you go through the CBT course week by week, and the computer basically administers the therapy quite effectively. So there's now compelling evidence that cognitive behavior therapy can help people with multiple sclerosis who become depressed. Next slide, please. Another very useful therapy is something called mindfulness training. Next slide, please. Now, don't worry about all the lines and dots over here in this cartoon, but you're going to see two broad pictures over here. On the left-hand side of the screen refers to the original treatment data. On the right-hand side of the screen, these are data 6 months after the mindfulness therapy was completed. When you have a look at the lines that I have the open circle, the lines at the top, this was a group that received mindfulness-based therapy, and the dark squares at the bottom are the group that got usual care. When you see the red circle over there, CESD, that refers to depression scores. The green circle, MFIS, refers to fatigue scores. And what you can see in this cartoon is that the individuals who got mindfulness-based therapy showed significant symptom improvement. Those are the lines across the top over here in which you have the dots. Not just for depression, but also with respect to fatigue. But this is where it gets interesting. 6 months after therapy was complete, after the person completed their mindfulness sessions, the benefits were still there for depression and still there for fatigue. In other words, mindfulness therapy can help depression. It can help fatigue, and after therapy ends, the benefits remain for at least 6 months. Next slide, please. So what is mindfulness-based therapy? Well, this was pioneered by John Kabat-Zinn, and the principles behind it is to help individuals focus their attention on the present moment experience. And in doing so, you become more aware of your thoughts, your feelings and actions that can hinder your progress through life. And what typically happens is when someone becomes depressed or anxious, they tend to shy away from worrying things. It's uncomfortable to sit with your anxiety and your sadness. But what mindfulness therapy does, it helps you stay in the moment. It helps you stay with your negative thoughts, and you develop strategies to deal with them, and you master these negative thoughts. So it can be a very effective way, like CBT, of helping you with your depression. Next slide, please. This is just to show you what the data is like for mindfulness-based interventions. Next slide. And what you can see over here is that it's been applied to people with multiple sclerosis who have anxiety, depression, stress, and from all these dots running down here, this basically shows that no matter what your condition is, mindfulness therapy can be modestly effective in helping you with your symptoms. I should add, of course, that mindfulness-based therapy, like cognitive behavior therapy, has no side effects. Next slide, please. What about exercise? Well, there's promising data as well. The next slide, please. This shows you a number of individual studies over here. And basically, look at the line running down here, this cartoon. Every dot to the left of this line indicates that this study was clinically effective. In other words, you got a good result from exercise. And the overall red star at the bottom over here says that exercise may indeed be modestly helpful when it comes to depression in people with MS. Next slide, please. And just as effective as this, yoga and going for a walk might elevate a person's mood. So the bottom line behind these data is this. You want to try and be active. You want to try and get some physical activity. By doing that, you can elevate your mood. You might be able to help your depression. I don't believe the data from exercise and yoga are as good as they are for CBT and mindfulness, but nevertheless, it's an important point. Exercise, yoga, Pilates, things like that, when you get involved in that kind of physical activity, there may be benefits for your mood as well. Next slide, please. What about medications? Well, it's easier to take a pill than to engage in 16 weeks of CBT. And the data show that medication can be effective, but medications do have side effects, things like dry mouth, constipation, some sexual difficulties, perhaps weight gain. The clinician can tailor the antidepressant medication according to symptoms and side effect profile. That's important as well. So antidepressants differ in how they work, and a doctor who's familiar with these antidepressant medications can choose a particular drug that matches your clinical profile. In my clinical practice, I generally go with CBT first, mindfulness second, medication third, but I do offer my patients a choice. And there are individuals who will choose medication as a first choice. And if they do, I will tailor their drug therapy according to what their symptoms are. Next slide, please. I'd like to finish with a couple of slides from research just showing you how powerful psychotherapy can be. Next slide, please. This is a study showing that stress reduction is not only helpful in terms of stress, but can also have a beneficial effect on your MRI. And if you have a look at the study over here, it was 24 weeks of therapy. People with MS were assigned to stress reduction therapy or no therapy. They underwent regular brain MRIs. They were given contrast enhancement, gadolinium, which shows you whether there's disease activity. And the individuals who got the stress reduction, those in blue, showed less lesions in the brain and less contrast enhancing lesions while they were getting the stress reduction therapy. Isn't that interesting? So the psychotherapy, the stress reduction, wasn't just helping their stress, but was having a beneficial effect on the brain MRI. The moment therapy ended over here, then the brain MRIs in the two groups came together. But certainly this is a powerful example of how important psychotherapy can be. The next slide, please. And the point is made again over here that coping strategies, good coping strategies, the part that are put down in the red box at the bottom, this too can have a beneficial effect on your brain MRI. So why might that be? Why might psychotherapy have this beneficial effect on what's going on in your brain? The next slide, please. And evidence for this comes from looking at the immune system. Next slide, please. Lots of data over here. Don't worry about all the small little numbers. What you see in this big red oval here are studies that showed psychotherapy having a beneficial effect on your immune system. That effective psychotherapy, in particular cognitive behavior therapy, can affect your immune system. You will have less inflammatory cytokines, less inflammatory disease activity, because the therapy is reducing your stress and your immune system starts resetting as a result. And because of that, you can have knock-on benefits affecting your brain MRI. So everything is linked over here. The talk therapies can be very powerful. They affect your immune system in a beneficial way. That in turn can affect your brain MRI and your disease activity. And that's why you see an improved pattern on brain imaging. Next slide, please. So in conclusion, we know that adjustment difficulties are common after being diagnosed with multiple sclerosis. Symptoms of depression are common in people with MS. But this is the upbeat message. There are good, effective coping strategies that can be learned if necessary. There are good, effective psychotherapies as well for depression and MS, cognitive behavior therapy, mindfulness therapy. Remember that when it comes to coping, problem-based, problem-focused coping is good. Avoidance is bad. Antidepressant medications can offer benefits as well. Your medication can be tailored according to your clinical profile. And the take-home message is this. There's no doubt that MS is a tough disease, and I'm not trying to minimize that. But every difficulty that I spoke about today is potentially treatable with the therapies that I've outlined. So on that note, I would just like to thank the Multiple Sclerosis Society of Canada in particular for funding my study over the years, and I'd now be happy to take some questions from you. Thank you.
That was absolutely fascinating, Dr. Feinstein. A very informative presentation. And I do have a question of my own to get things started. Would it be a good idea to suggest an initial therapy session to somebody who is newly diagnosed with MS to encourage good coping skills upon that diagnosis?
I think that's an excellent idea. Setting the tone early on in this disease is very important. And I believe very firmly in education. When people understand what works, then you become informed as a patient. Then you can make the right kind of decisions. And so, psychoeducation provided early on, I think, is a very important part of managing this disease. Now, there may be an issue in terms of resources. How do you get access to that? And I recognize that will vary widely according to where you live. But the idea of getting an appreciation of what's available treatment-wise early on in your disease is a very important thing. I'm very glad you made that point. I would endorse that strongly.
Okay, thank you. I think we will go to some questions that we have. Let's see. Is there a way to differentiate fatigue associated with MS and fatigue associated with depression?
Yes, there is. And that entails, first of all, that's a very common problem. So it's an excellent question. And there are ways to tease it out. When you get fatigue that's linked to depression, there will be other depressive features as well. The sad mood, or the irritability, or the inability to enjoy things. There may be the typical sleep disturbance that comes with depression, which is early morning waking. The individual wakes up at about 4 a.m. and cannot get back to sleep. There may be changes in appetite that are described. Appetite increases, you eat excessively, or you lose your appetite and you lose weight. There may be feelings of guilt or worry or poor self-esteem. Concentration may be impaired. And, in the most extreme form, the person wonders whether life is worth living. That's the constellation of depression, symptoms of depression, of which fatigue can be a part of that. When you get fatigue on its own, fatigue is a standalone symptom, you don't get the other difficulties typically that are described to you. And so by taking a careful history and teasing out the symptoms, you can often distinguish, is this fatigue that's part of a major depression, or is it standalone fatigue? That said, you may of course have both. You may have fatigue associated with depression plus standalone fatigue. And that will become apparent when you go for treatment, your depression is successfully treated with CBT, but you still feel tired. You've got the leftover fatigue, and then I've got fatigue as a standalone problem. And fatigue is very, very common in people with MS. And there's data to show that people with MS often list fatigue as one of their three biggest complaints. And it can be hard to treat. There's some data to suggest that cognitive behavior therapy may help fatigue by itself. There's also some anecdotal evidence that stimulant medication may help fatigue. And certainly in my clinical practice, I use stimulant medication. You've got a choice of drugs. Although I should say that a recent review that came out in Lancet Urology called into doubt the effectiveness of the stimulant medication. But that said, I know from my clinical practice that some patients can respond very well to stimulant medication. So, this is a long answer to a simple question. But through careful clinical inquiry, through the use of targeted medications, you can often tease out standalone fatigue or fatigue linked to depression.
Okay. Our next question is how to get proper help with your MS neurologist around how often should you see your neurologist, how often should you have MRIs, blood work, and help and support once you're on a disease-modifying therapy.
Right. So now you're asking a psychiatrist a question that I'm not completely qualified to answer. I mean, this is a question that really should be addressed to a neurologist. I'm a psychiatrist. I'm very familiar with the disease-modifying therapies because I see lots of people with MS. But ultimately, this is a question that's going to be answered by your treating neurologist. I know from the way we work in our clinics is that every individual with MS has at least a yearly follow-up appointment with their neurologist, that the MRIs are repeated, often yearly, to get a sense of disease activity. You know that your MRI is a very important biomarker of what your disease is, that the decision about what disease-modifying drug to use or whether you need to change drugs can often be based on what your neurologist sees on your brain MRI. So the MRI becomes very important in terms of clinical decision-making. But ultimately, these decisions are going to be made by your neurologist. From my perspective as a psychiatrist, what I recommend is this, that when everyone gets the diagnosis of multiple sclerosis, they would benefit from at least one session with someone like myself to talk about things like depression or cognition, which we haven't even touched on here. And then depending on how you're feeling, you will then get a management plan relating to your depression or your mood difficulties. If it turns out that I'll quickly finish. If it turns out that you enter a cognitive behavior therapy program, then it's usually 12 to 16 sessions once a week.
Okay, sorry for interrupting you there. Our next question has to do with nerve pain and MS spasticity and medications like baclofen. How does one know what's best, and how should one expect to feel as a best case scenario?
Right. Well, once again, that's going to be a question that's best addressed by your neurologist because of spasticity, right? When it comes to nerve pain, then there's often an overlap with the kind of work that I do, because what you're talking about is neuropathic pain, pain linked to the disease process of multiple sclerosis. And there is evidence that certain psychiatric medications can be effective for nerve pain. The one that's most frequently used is duloxetine. It's known as Cymbalta. So Cymbalta is the trade name. Duloxetine is the generic name. And that's good, not just for depression, but also for neuropathic pain. And so if an individual has neuropathic pain associated with depression, and depression and pain often go hand in glove, then a drug of choice may well be duloxetine. There's also evidence that the older antidepressant drugs, the tricyclic antidepressants, drugs that like amitriptyline or nortriptyline or desipramine, these drugs may indeed have analgesic properties as well that can help with neuropathic pain. But the older antidepressant drugs like these have more side effects, but they can be quite effective in dealing with neuropathic pain. And then there are going to be a host of other drugs that are helpful with neuropathic pain. When it comes to spasticity, that's a question that's best addressed, I think, by your neurologist.
Okay, the next question. How do you explain to your family and friends about MS fatigue so that they don't think that we're just being lazy?
Yeah, that's a great question. And this crops up all the time. So, I'll give you the data. Fatigue affects many people with multiple sclerosis. As I mentioned earlier, people with MS often rate fatigue as one of the three biggest challenges with MS. Fatigue, like depression, like cognitive difficulties, is silent. When you look at someone, you typically don't see fatigue. People think multiple sclerosis is the disease of the cane or the wheelchair, etc. But it's not. It can be a disease of hidden things, quiet things like fatigue, depression, etc. So I think, education becomes critical in helping other people understand what you're going through. What I often do in my clinic is when a patient asks me a question like this, I say, well, let me offer you a session with you and your family members. Let's have a psychoeducation session. Let's talk about this. Let me try and explain to your partner, to your spouse, to your parents, to your children, whatever, about the hidden symptoms of multiple sclerosis. And this is relevant not just for fatigue, but also for depression, for cognitive problems, etc. And that can come as a revelation to family members. So, there's nothing to be lost about education. Educating people about the disease, educating family members and loved ones about your disease is very much part of your clinical care. And through education, you start changing the way people view things. From my perspective, I see how difficult it is in which I have a person with MS, a patient who's battling a disease, but they have the added burden of people judging them in a negative way, calling them lazy, or you're not trying hard enough, or you're not doing this, or you're not doing. So all these kind of value-laden judgments come in that are very negative, which kind of add to the burden of the disease. And the way to address that is through education, through psychoeducation. Now, the MS Society of Canada has a very good website for resources. The MS Society in the United States has a good website as well, so you can pull some material off their websites in terms of education if you can't get one of those sessions with a neurologist or a psychiatrist like myself.
Okay, I think it's a very good idea to get the whole family involved, only because MS is just not an individual illness or disease. It affects everybody in the family.
I think that's quite right. Absolutely. And that's a very good point, because that's absolutely true for depression. If you're depressed, your family members feel it. It's hard to live with a depressed person. Your sad mood, your despondency spreads. It can affect other people, your partner, your children, etc. And so it really becomes a family issue. And so education can be so important in terms of helping family members as well.
Okay, here's a question from Danielle on Facebook. How often do you see people expressing challenges with cognition and executive functioning related to their MS, and what would you offer them for a treatment plan?
All right, so that's a very different question, unrelated to depression, of course, but you're touching on cognitive difficulties linked to multiple sclerosis. And that, of course, is one of the silent problems that I spoke about earlier. Cognitive dysfunction is very common in people with MS. And the rates go up according to the kind of MS that you've got. If you've got relapsing remitting disease, the prevalence rate is about 40%. If you have secondary progressive MS, it goes up to about 70 to 80%. If it's primary progressive MS, even as high as 80 to 90%. So cognitive problems are very common. And you can get a whole array of cognitive difficulties. They can range from processing speed impairment, which is probably the most frequent cognitive difficulty, to challenges with memory, to challenges with executive functioning, which is the question that your Facebook participant asked of me. When people say, well, what is executive functioning? That refers to your ability to plan, to sequence, to problem solve, to think out the box, abstract thinking. Executive functioning is critical to how we lead our lives. So we take information and we utilize information in a way that helps us. Well, we utilize it through executive functioning, through planning, through sequencing, etc. And there's evidence to show that between 15 and 20% of people with multiple sclerosis can have executive function difficulties. How do you treat that? Well, in many ways, the treatment here is more problematic than it is for depression. But there is an emerging literature that is quite promising that suggests that cognitive rehabilitation might be able to help individuals with cognitive problems. Now, cognitive rehab is not the same as cognitive behavior therapy. I realize these terms can become confusing. Cognitive behavior therapy, CBT, which is what I spoke about in my presentation, is for depression. Cognitive rehabilitation is for problems with memory and executive functioning and processing speed. Now, cognitive rehabilitation is given in hospital, a number of different ways that you can do it. They computerized programs that now do cognitive rehab. And as I say, there's an emerging literature to suggest that it might be able to help you with the cognitive problems that this reader's just identified.
Okay, here's an interesting question. Is MS connected to dementia and Alzheimer's?
Right, so MS is not Alzheimer's. I'll say that again. MS is not Alzheimer's. There are two different diseases, fundamentally different diseases. Now, because MS is quite common, and because Alzheimer's is very common, occasionally it's possible that an unfortunate individual gets both, just by chance, right? But they are fundamentally different diseases. The question is, can MS by itself give rise to a dementia? Not Alzheimer's, but can MS give rise to a dementia? And occasionally you see individuals with MS who have such profound cognitive problems, it comes across as a dementia. But that's unusual. And here's the important thing. Alzheimer's disease is progressive. Individuals will get it, always decline. When individuals with MS get cognitive problems, you don't necessarily have to decline. The cognition remains fixed. It may remain unchanged depending on how your disease progresses and depending on the therapies that you take. So bottom line is these are two fundamentally different diseases, although both affect cognition.
Our next question has to do with pseudobulbar effect. They're asking what it is and how can it be treated?
Right, so this is a really interesting clinical phenomenon. So pseudobulbar affect refers to people who cry when they don't feel sad, or they laugh when they don't feel happy. So there's a disconnection of your subjective inner emotions from your outward display of emotions. Typically when someone cries, you feel sad. When you laugh, there's mirth. You feel happy. But in 10% of people with multiple sclerosis, the laughter or the crying is not accompanied by these subjective emotions. And that's called pseudobulbar affect. It's a disconnection of the outward display of emotion from what you're feeling. And that can be very frustrating for someone, as you can imagine. An individual can't stop crying and you don't feel sad. Everybody thinks you're sad, but you're not. You just can't control the flow of your tears, the mechanism that drives crying. The good news is that it responds very well to medication. There's a medication in the United States that received FDA approval. It's called Nudexta. And Nudexta is a combination of dextromethorphan, which, believe it or not, is a cough syrup, combined with quinidine. And essentially what this combination does in a pharmacologic preparation is it turns off this excessive crying or excessive laughter. And my understanding is that this medication is now available in Canada. So it's a very effective treatment. And it generally turns off the excessive laughter or crying within about 72 hours. What's interesting is that some of the antidepressant drugs like fluoxetine or Prozac, or the old tricyclic antidepressants like amitriptyline, can also help pseudobulbar affect. But with those drugs, you might get the side effects that I described earlier, like dry mouth, constipation, weight gain, sexual difficulties, etc. So pseudobulbar affect is not that common, but it can be very well treated with medication. Now, psychotherapy is not going to help pseudobulbar affect. CBT won't help. Cognitive behavior therapy, mindfulness will not help, because this is a hard-wired neurological condition that will only respond to pharmacotherapy. In particular, the kind of drug like Nudexta, which combines the cough syrup, dextromethorphan, with quinidine. And one final thing, which is really quite fascinating. You may ask yourself, why on earth would a cough syrup help my crying? Now, the answer is this. When you look at the neural pathways, you have multiple networks throughout the brain that funnel down into a part of the brain called the brainstem before they go into the spinal cord. And in the brainstem, you have what's known as the bulbar nuclei, and the bulbar nuclei are critical. They control your respiration, heart rate, but they also control the cough reflex, and they control a number of those basic reflexes that are implicated in laughter and crying. And so by suppressing the function of your bulbar nuclei, you prevent individuals from laughing or crying. So, dextromethorphan wasn't developed as a medication for laughter and crying. It was developed as a cough syrup to suppress the cough reflex, which it does very effectively. But in doing so, it also turns off, as it were, the bulbar nuclei that are important in terms of laughter and crying. Now, if you go out and you buy dextromethorphan from your Shoppers Drug Mart, that's not going to help your laughter and crying. You've got to take the medication called Nudexta because it's combined with quinidine. And quinidine fundamentally alters the blood levels of dextromethorphan and pushes up the concentration of dextromethorphan to a level that can help your laughter and crying. So it's one of these really interesting serendipitous pharmacologic findings showing you've got a treatment that was initially developed as a cough syrup, which, by the way, can help your laughter and crying that's pathological.
That's pretty cool.
Yeah.
Okay, you mentioned that people following psychotherapy or CBT have better MRI outcomes. Does that mean that the lesions are reduced? And this person is saying that their neuro has been saying that the lesions never disappear or shrink, and they would like to have your opinion.
Well, what the data show is that stress reduction therapy and therapy that focuses on coping strategies and helps with coping does indeed alter the brain MRI. So you could potentially have less contrast enhancing lesions. And what are those? Well, you get this contrast enhancing material called gadolinium, which essentially shows you whether you've got disease activity or not. So if your brain lights up with gadolinium enhanced lesions, it says to you that you've got active disease. Well, stress reduction therapy and coping strategies can reduce the number of gadolinium enhanced lesions. In other words, it reduces the level of disease activity. Plus, it can reduce the number of active inflammatory lesions that you might have in your brain. So if you respond well to stress reduction therapy, if you respond well to good coping strategies, then potentially you may modify what your brain MRI shows. And the mechanism for doing so is that you alter the inflammatory response, as I showed you. The data shows that good psychotherapy alters your immune system. It leaves you in a more robust immune state. And because of that, you see an improved MRI picture. So yes, your brain MRI can indeed improve if you respond well to the psychotherapies that I outlined.
Okay. This next question kind of hits home for me because I kind of reacted the same way when I was diagnosed almost 25 years ago. This person says they were diagnosed recently, but feeling surprisingly positive and not as anxious as I thought I would be when diagnosed with such a serious condition. Am I in denial? Should I be trying to give myself more reality checks? Does it even matter in terms of a journey to acceptance?
Yeah, no, I think that's a really excellent question. The bottom line is no. Not everybody who gets this diagnosis will have adjustment difficulties. There are many people who adjust immediately and well. There's a whole spectrum of responses. My talk has focused on those people who don't adjust well because they're the ones who get referred to me. But many, many people will adjust well to it. Many people with multiple sclerosis will never develop depression or adjustment difficulties. I showed you the data. Between 50% and 75% of people with MS will not become depressed. They adjust well. And so, yes, the fact that you don't become depressed, don't feel bad about that. Good for you. You've got a resilience and go with it. That's great. But, because I'm a physician and people get referred to a physician when they're not well, I see that spectrum that's depressed. People who don't cope, who are anxious, who are sad, they come to see me. But there are going to be many people who do not need to see me.
Okay. Somebody is asking, how do we join your study? So I would preface that by saying, are you continuing to do studies in MS research?
There will always be studies, yes. And generally we advertise our studies through the Multiple Sclerosis website, the Multiple Sclerosis Society website. We've just wrapped up a very big study looking at cognitive rehabilitation in people with progressive MS. And I coordinated an 11-center, 6-country study looking at cognitive rehabilitation and exercise in people with progressive MS to see if we can bring about cognitive improvement. We're analyzing this data now. We're busy with a very new experimental kind of treatment for depression, transcranial magnetic stimulation. And that's applying a magnetic field force to the brain to see whether this can improve mood. Right now, we're in the middle of a study like that. And we're always looking to recruit people for a study like that. Now, this is in Toronto. It would mean having to come to Sunnybrook Health Sciences Center for the treatment. But there are always going to be ongoing studies. And people who want to volunteer, that's wonderful of you. I'm very grateful for your time and your effort. And you can always reach me through my Sunnybrook office. So thank you.
Okay. Our next question has to do with something that I know you're familiar with as you presented on your research from 20 years ago. And this person is asking, is there research with MS patients who may have had a major depression prior to, by at least a decade, MS symptoms developing and then eventual diagnosis?
Right. Fascinating question. There's now emerging data from researchers like Ruth Ann Marie out in Winnipeg, and also from some of the Scandinavian groups, that in the period prior to the diagnosis of multiple sclerosis, in other words, before the individual gets the diagnosis, when you look at their healthcare utilization for 2 or 3 or 5 years prior to their diagnosis, these individuals are going along to physicians more frequently than people without multiple sclerosis. So there's an increased health need, and often it's because of anxiety and depression. So there is some evidence emerging that as a prelude to the diagnosis of MS, there may be some increase in symptoms of anxiety and depression. So that's an interesting, that still needs to be teased out further. The question, we're not too sure why that might be, but there does appear to be some robust epidemiological evidence. Remember, this comes from studies with large numbers of patients, very big databases, showing that the frequency of attending a healthcare provider is increased in the 3 or 4 years prior to the onset of multiple sclerosis. Interesting question. Interesting answer. Yeah.
Okay. Could it be eventually part of the MS prodrome?
Yes, may well be. What I've shown you in my brain imaging data from my lab and from other labs is that we think we can link depression directly to the brain changes. That's not surprising. MS is a brain disease. Depression comes from the brain. So, if we've got sophisticated brain imaging like we have now, we can show that if you've got lesions in a particular part of the brain or shrinkage or atrophy in certain brain regions, this leaves you vulnerable to developing depression. So potentially, the inflammatory responses that drive multiple sclerosis may be clinically, neurologically quiescent or quiet in the 3 or 4 years before the disease manifests itself. But those changes that are percolating, as it were, in the background may be enough to be triggering some anxiety and some depression that drive people to request help. And then you cross a threshold and the MS disease becomes apparent. So that may well be the process that's underway over here.
Okay, I could talk to you all day about this, but we have come to the end of our time for questions. So thanks again, Dr. Feinstein, for your presentation. Brilliant. Wonderful. Before we wrap up.
Sure, and let me just thank you as well. I want to thank the audience as well for really excellent, very focused and informative questions. So thank you for the opportunity to address you.
Very glad to have you. We do want to remind you about the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. I know this personally speaking. You can connect by phone, by email, or live chat through the MS Society's website, and you can know that the interactions and information itself is trustworthy. Now, if you'd like to sign up for the monthly e-newsletter, an MS Navigator can help you do that as well. When you receive the e-news, you are kept up to date on the latest MS research and treatments, the Society's programs and services, fundraising and volunteer opportunities, inspirational personal stories from people affected by MS, and so much more. And all of it is delivered to your email inbox each month. So we invite you to be part of the MS community, encourage you to get involved with the programs, the services, the events, and volunteer opportunities. These days, connecting is more important than ever, and more information is available on the website at www.mssociety.ca. Also, we encourage you to visit wechallengems.ca to learn about how you can help to raise funds which are needed to maintain our research commitments, advocacy initiatives, and programming to support those affected by MS. Now, very soon you're going to receive a survey by email about today's webinar, and we encourage you to fill it out. For the Facebook Live audience, the link to the survey is already available at the top of the chat, and we ask that all viewers complete the survey. The information that's collected from the evaluation will let us know if today's discussion was valuable to you and what topics that you would like to see covered in the future. It will only take a couple of minutes, and your feedback will go a long way to help us when planning for future educational sessions. So, on behalf of the MS Society of Canada, thank you for tuning in for today's broadcast. Bye-bye.